All right, so in this video, chapter 23, we're going to look at disorders of ventilation and gas exchange. So we're going to first define this term, hypoxemia. It's similar to hypoxia, except for this is going to be a PO2 that's greater than 60 but less than 79, but in the blood. So it's hypoxemia when referring to the O2 levels of your blood, and this is going to be more associated with things like cyanosis or ballooning of the skin. Now, what can typically lead to hypoxemia is impaired function of the vital respiratory centers. And so what we'll find then is that if your brainstem is inhibited, you can see that individuals may become agitated or combative. They may have senses of euphoria, impaired judgment, convulsions, delirium, even stupor and coma are severe examples. These individuals may also have retinal hemorrhage, and this is due to massive vasodilation within the retinas, causing leakage of blood. And then we also have hypotension and bradycardia as a result of basically your cardiac muscle not able to produce enough ATP to pump effectively. Now, in terms of activation of compensatory mechanisms, you're going to see a lot of sympathetic nervous system activity. So individuals with hypoxemia will have like a decrease in bowel sounds. They'll have kind of cold, clammy, sort of sweaty skin, and possibly even an increase in heart rate and blood pressure. Now with hypercapnia, we're saying this is a PCO2 level greater than 50 millimeters of mercury. And this is abnormal because typically venous blood has PCO2 levels about 40 millimeters of mercury or so. And so this is going to be associated with things like respiratory acidosis. Now, the compensatory response here would be to increase your respiration rate, your ventilation rate, but it may also lead to things like decreases in nerve activity. So we could see disorientation, somnolence, which is basically sleepiness, coma, even carbon dioxide narcosis. And we'll also see a decrease in muscle contraction. And because of this, you can see things like vasodilation, so that your blood vessels lose their smooth muscle tone, and this can be associated with things like warm, flushed skin, as well as headache. Now this question here says, true or false, both hypercapnia and hypoxemia will lead to a respiratory failure if untreated. And that's absolutely true, because in both hypercapnia and hypoxemia, tissues accumulate lots of carbon dioxide. In hypoxemia, it's the PO2 less than 60, but less oxygen is delivered to tissues, so in both cases gas exchange is impaired and respiratory failure can result unless it's corrected adequately. So we're going to talk about the pleura in this next part. And so earlier we learned about how the pleura are going to function to help to maintain the patency or openness of your lungs. And they do this by basically anchoring your lungs to the inner thoracic wall. And this works because the outside of your lung has a visceral layer, and then the inside of your thoracic wall has a parietal layer. But because these two are continuous with each other, the visceral and parietal layers basically hold the lungs to the inner thoracic wall. And these are separated by a pleural cavity, which is filled with a very thin layer of serous fluid, which is a lubricant. Now, if this gets damaged, then individuals' lungs could collapse because now their lungs aren't being held to the inner thoracic wall. And so this could happen in conditions like pleural effusion. So an effusion would be basically just an accumulation of some sort of fluid in the pleural cavity. And it could be serous, which we call hydrothorax. It could be made of pus, and in that case we call it empyema. It could be made of lymph, we call it chylothorax, or if it's blood, we call it hemothorax. Now if there's air that's actually started to accumulate in this pleural space, we call it pneumothorax. But these are all examples of fluid that can accumulate in the serous space, and this could all limit the expansion ability of your lungs. So the scenario here says Mr. K presents himself with a stab wound, and now that he's having breathing problems, his breath sounds are diminished on the side of the wound, and his trachea seems to be slanting towards the other side of his chest, and his heart sounds are displaced away from the wound. He has increased respiration rate and blood pressure, is pale and sweating with bluish nail beds, and has no bowel sounds. So explain the effects of the wound. Well, essentially what's going on here is the stab wound would be in the thoracic region. The breathing problems would come about because of a collapsed lung. And in fact, that's why you can't you can't hear many sounds of the lungs from the side of the wound because it's collapsed. When your lung collapses, the trachea actually deviates to the other side because now the other lung that's still inflated will pull the whole trachea off to the, that other side because the other lungs collapse and it's not going to pull as much. So his heart sounds would be displaced because if the trachea is being pulled over to the other side, the other lung is going to be pulled to the other side too, which is going to pull your heart over as well, which is going to displace the location of heart sounds. You're going to see an increase in respiration rate because of compensatory effects of low blood oxygen. Also an increase in blood pressure, also to help compensate for low blood oxygen. You can be pale, sweating because of and no bowel sounds because of a compensatory sympathetic response, and then bluish nail beds because of the hypoxemia. So with pneumothorax, air enters the pleural cavity, and this is probably what was going on in Mr. K in the last example there. Now with pneumothorax, air takes up space, which restricts lung expansion. Now we're seeing that this air actually is found outside of the lung, and therefore prevents the lung from being able to fully expand within the thoracic cage. Now partial or complete collapse of the affected lung can happen under different conditions. Now if we call it spontaneous pneumothorax, what's really weird here is we're seeing that air-filled blister on the lung ruptures. So the spontaneous pneumothorax is when air from within the lungs leaks outside of the lungs, and then that air starts to build up outside of the lung, which prevents proper lung expansion. That's spontaneous pneumothorax. Now with traumatic pneumothorax, it either could be tension or open, but in either condition, we're saying that the wound is on the external surface of the thoracic cage, so air is leaking in from the outside. Now with tension pneumothorax, air enters the pleural cavity through the wound on inhalation, but can't leave on exhalation. So imagine with every breath, tension pneumothoraxes start to accumulate more and more air within the thoracic cavity, and that air can't leave when you exhale. Now with open pneumothorax, air enters the pleural cavity through the wound also on inhalation, but it's able to leave when you exhale. So with open pneumothorax, you'll find then that there will be inadequate expansion of the lung tissue, but air won't accumulate within the thoracic cavity because it can actually leave when you exhale. So if you look at this example here, let's say with open pneumothorax, and here's our wound here. Now what's interesting then is what we're saying is that the wound, and on inhalation, air enters the pleural cavity here, and you can see that the lungs collapse because it's no longer anchored to the inner thoracic wall, and this this air that's accumulating in the space is starting to limit the expansion ability of the lung itself, so it's collapsed. And what's interesting too is you can see that the trachea is going to deviate to the other side, because if this lung is still adhered to the inner thoracic wall, it's going to pull everything else over with it, which is also going to displace the heart a little bit as well. In fact, this dotted line shows the midline, so you can see how much the heart's displaced to the left, which is obviously abnormal. Now remember, with open pneumothorax, it's obviously traumatic because we actually have a hole here on the external side of our thorax, but the air can leave when you exhale. And so you still get partial inflation of the lung when you exhale. Now this isn't as bad as tension pneumothorax, because with tension pneumothorax, air enters the pleural cavity on inhalation, but this flap of tissue can close when you go to exhale, and then the air can't leave. So basically just the air starts to accumulate more and more and more within this pleural cavity so that the lung never really inflates. It actually stays fully collapsed here. So true or false, open pneumothorax is more life-threatening than tension pneumothorax. Well, we just talked about how that's false, right? Because in open pneumothorax, inhaled air compresses the affected side's lung, but some of that air can leave during exhalation. That's not true with tension pneumothorax. With tension pneumothorax, air enters on inhalation, and it can't leave on exhalation. So all it can do is just accumulate more and more and more inside of the thoracic cage. So we're next going to move on to talk about airway obstruction, and specifically with respect to asthma. So asthma is an inflammatory condition of the lungs, and what we find here is that the airways become inflamed, which increases mucociliary functions. You get a lot of mucus that builds up. We can also see edema as a consequence of increased vascular permeability, and if there's too much inflammation, we can see damage to the epithelium over time. Now, in asthma, we also see increased airway responsiveness, and they become hypersensitive to things, whether allergic or non-allergic, and this can lead to things like bronchospasms, where the smooth muscle of your airways starts to spasm, and this ultimately limits airflow because of an increase in resistance. Now, with extrinsic or atopic asthma, we think about this as being allergic asthma. Now, this is the more common form of asthma that you're going to find in children. It's less common in adults, but it's a type 1 hypersensitivity, so it's due to some sort of allergen. Now, mast cells will release inflammatory mediators like histamines, and this is what causes the acute response within minutes. White blood cells can enter the affected region, releasing more inflammatory mediators, and this can lead to inflammation that leads to a late phase response within 4 to 8 hours. But an asthma attack can be acute and chronic depending on how long the inflammation occurs for. What's important to note, though, is that asthma is a life-threatening condition. Because of this inflammation, it starts to cut off the airways, which increases resistance, and that decreases airflow. So with bronchial asthma here, let's imagine with our antigen, and this might be the allergen itself. Now, when it binds to IgE immunoglobulins on mast cells, it can trigger mast cells to release cytokines like histamine. Now, this in itself can cause bronchospasms by smooth muscle contraction, and if you look at the diameter of the airway here, because of smooth muscle contraction, you get a decrease in the diameter, which increases resistance and decreases flow. Now, over time, we can actually get destruction of the epithelium and accumulation of mucus, which can also make the airway even more constricted and have even less airflow. Now, some of these inflammatory mediators also cause an increase in vascular permeability, which leads to mucosal edema, which further increases the swelling. So you can see that acutely you get some sort of narrowing of the bronchioles in some of your larger airways. But over time, we actually see that there's a heightened airway responsiveness, and so it further limits the diameter of that airway, which really decreases airflow. You can see how small the lumen is here, even versus before, which this is still technically a bronchospasm. So with intrinsic or non-atopic asthma, we think about this as being non-allergic, and it's more common in adults, but also has poorer outcomes because it's often difficult to find the source of the asthma. Now, it cannot be associated with things like respiratory infections, which can lead to epithelial damage and production of IgEs. It can be associated with exercise and hyperventilation. And so the belief here is that exercise-induced asthma causes a loss of heat and water, and this might trigger osmoreceptors that can lead to bronchospasm as a result. So it's particularly worse in cold air because cold air is less humid. And if it's drier, you're going to lose more water, which is going to lead to a stronger bronchospasm response. Now, it may also be due to inhalation of irritants, which can lead to inflammation and a vagal reflex. And then it might also be associated with certain drugs like aspirin or non-steroidal anti-inflammatories because of a genetically linked abnormal arachidonic acid metabolism, which still isn't well understood. Now, this question here says, which of the following occurs in asthma? Airway inflammation, bronchospasm, or decreased ability to clear mucus? And it's actually all the above. And the reason why we see a decreased ability to clear mucus is from destruction of the epithelium that lines the lumen over time. And so that mucus just starts to accumulate along airways, which makes it more and more difficult to ventilate. So with chronic obstructive pulmonary disorders, this includes emphysema, what we see then is actually an enlargement of the air spaces and destruction of lung tissue. This is much different than asthma because although asthma leads to destruction of the epithelium, and you do get some hypertrophy of the airway, with chronic obstructive pulmonary disorders, this actually leads to destruction of the alveolar septa. And so what you get then are large air-filled spaces within the lungs. Now this is bad because the air becomes trapped within the lung tissue itself. Now with chronic obstructive bronchitis, we see obstruction of smaller airways, and bronchiectasis is an infection and inflammation that destroys the smooth muscle in the airways of your respiratory tract, and this actually causes permanent dilations. And so bronchiectasis is these little dilation blebs that stick out along the airway, but that also leads to the production of mucus, and it can limit proper airflow. So in terms of the mechanisms of airflow obstruction, if we look at the normal structure of the lung tissue, we find with our airways here, like let's say the bronchioles, we have a bronchial wall, we'll have some smooth muscle there, but in the stroma of the lung tissue, you're going to find a lot of elastic fibers. And these lumen are pretty well open. Their diameter is wide, which is going to increase airflow. Now, if you compare this to different conditions, like over here, what we find then is that if there's too much inflammation of the bronchial wall, this can actually cause the diameter to decrease, which is going to decrease airflow. We can also see obstructions from mucus, like if there's excessive mucus production, this also decreases the diameter of the lumen, so it decreases airflow. And in certain conditions, we actually get destruction of the elastic tissue, which prevents proper compliance of lung tissue, so air gets trapped in these spaces, even though they're not that small. So with COPD, or chronic obstructive pulmonary disease, we think about this as being like emphysema. We see inflammation and fibrosis of the bronchial wall, but this is chronic, so this is going to occur over the course of decades. Now, due to this chronic inflammation, hypertrophied mucus glands secrete excessive mucus, which obstructs proper airflow, and that from excessive inflammation, we also get loss of alveolar tissue, so that ultimately we see a decrease in surface area for gas exchange. So in the long run, individuals with COPD have a lot of difficulty with proper gas exchange or respiration. And that we also see destruction of the elastic lung fibers, which prevents proper relaxation of lung tissue, so that air gets trapped in these large spaces that have started to occur from loss of alveolar tissue. It can also obstruct exhalation and collapse airways. So with emphysema, neutrophils in the alveoli secrete this thing called trypsin. Now, trypsin is also called elastase, and as an enzyme, it breaks down elastin in the lung tissue. We talked about how elastin is one of the contributing factors to lung compliance, and if we get too much trypsin release, this could damage the alveoli by basically destroying the surrounding elastic tissue. Now, alpha-1 antitrypsin inactivates trypsin before it can damage alveoli normally. However, if you have neutrophils releasing too much trypsin, it can override this sort of inhibitory effect. Or individuals with genetic defects in alpha-1 antitrypsin can also lead to progressive alveolar damage due to inability to inactivate trypsin in the lungs. So with the different types of emphysema, you can find here, like if you look at normal lung tissue, we have our terminal bronchial, respiratory bronchial, which leads into our alveoli here. Now with this centricinar type of emphysema, what we see then is essentially these dilations of the bronchioles and also dilation of the alveoli, where air gets trapped in the lung tissue. Now, although this looks bigger and you think, oh, bigger is better, well, essentially it's bigger because of a destruction of the alveolar walls and the bronchial walls, so that there's actually less surface for gas exchange to occur, even though these airways look larger. There's less total surface area within this. And so if there's less surface area, then we get less respiration, so less gas exchange. And what we see here with pan-acinar types of emphysema is we see so much destruction of the alveoli, they're almost not even recognizable as distinct. Instead, we just get these large air-filled sacs that accumulate in the lungs where there's not even distinct alveoli. This is a problem because then you get a lot of air that gets trapped in the lungs, and that's going to limit proper gas exchange. Now, what's interesting too is that with individuals with emphysema, due to a loss of elastic fibers, their lungs have less compliance. So that in a normal adult, you can see here that the diameter to the width of their chest is a particular ratio. We see it's 1 to 2, right? Now, we said the anterior posterior diameter is 1, the transverse diameter is 2. That's a normal ratio of the chest wall. But in individuals with emphysema, because they really have to stress to ventilate because of loss of elastic tissue in their lungs, we see that they have hypertrophy of the muscles that are involved with forced inhalation. For instance, like their sternocleidomastoids get big, their scalenes get big, so do their external intercostals, as well as the ribs get larger, and they get this large barrel chest. And this is pretty characteristic of emphysema. In fact, if you look at the ratio of anterior-posterior to transverse diameter, it's totally flip-flopped. We actually see here that the anterior-posterior diameter is 2 to 1 rather than 1 to 2. And so you see a huge increase in thoracic volume. And this is really compensatory hypertrophy to try to basically increase ventilation ability due to a decrease in lung compliance. They're really having to work much harder to get air to flow. So with chronic bronchitis, it's actually going to be irritation of the airways that also increases the number of mucus cells, and you get mucus hypersecretion. Now, bronchitis, because of this excessive increase in mucus, you do see productive cough, and so we can differentiate emphysema from bronchitis in a variety of ways. Kind of an interesting term that we used to describe emphysema is called pink puffers. And the reason being here, with emphysema, you see an increase in respiration to try to maintain normal oxygen levels. You see shortness of breath and therefore increased ventilatory effort. That's why they're puffing up, right? And it's through the use of accessory muscles and pursed lip breathing, their faces can get kind of pink from that straining to breathe. And because they're really having to expand their chest out, they're kind of looking puffy. That's why they're saying pink puffers. And this pursed lip breathing would be like if you kind of like stuck your lips together as if you're pursing your lips. Where you really struggle to inhale, that's pursed lip breathing. And somehow that aids in the ability of these individuals to ventilate. Now, with blue bloaters, this is more associated with bronchitis because they can't increase respiration enough to maintain oxygen levels, so that we see things like cyanosis and polycythemia, which is an increase in number of red blood cells, which is a compensatory response to hypoxemia. But they're blue because they're cyanotic, and it can also lead to Cor Pulmonale, which is basically right-sided heart failure. Because if the lungs are so inflamed and you have a lot of resistance of mucus, it's going to put a lot more stress on the right side of your heart to pump blood to the lungs. So this question here says, which chronic obstructive pulmonary disease primarily affects the alveoli? Is it asthma, emphysema, bronchitis, or bronchiectasis? Well, we said it was emphysema, right? That was pretty characteristic of emphysema because we said that the alveoli and smaller bronchioles had destruction of the walls. This is what caused the trapping of air in those distal air sacs. Now, if we can contrast that to things like bronchiectasis, this was also dilation, but not of the alveoli, only of the bronchioles. With bronchitis, we're saying that it's inflammation of the bronchioles, but not the alveoli. And then asthma is just all over, especially upper airways too, like the larger bronchi and trachea. So with COPD, chronic obstructive pulmonary disease, it has an effect on individuals' blood pH, right? So remember, COPD was an example of emphysema. So this question here says, in what range will a COPD client's blood pH fall within? So we know that normal blood pH is 7.35 to 7.45. And with COPD, they're having difficulty with proper respiration and ventilation. So their blood pH is going to be lower because of hypercapnia, right? They're going to have an excessive accumulation of carbon dioxide in the blood because of a decrease in proper respiration. And so that their blood pH is going to be more acidic than normal blood pH, which should be 7.35. In fact, it could be as low as like 7.2. So some of the consequences of COPD would be like decreased ability to exhale. This is due to destruction of the elastic tissue in lungs. So we say that we have stale air within the lungs. When we think of stale air, that's trapped air, right? And the reason why that air gets trapped is that through that decrease in elasticity, the lungs don't want to, force that air out as easily. So that, that air gets trapped in the lungs. And this is going to lead to low O2 levels, which can ultimately lead to hypoxia. And then high CO2 levels in the blood, which can lead to hypercapnia. So this question here says, which step will cause the central chemoreceptors to increase respiration, and which will cause the peripheral chemoreceptors to increase respiration? We talked about how central chemoreceptors were sensitive to carbon dioxide, so that hypercapnia would cause your central chemoreceptors to increase respiration. And we said that the peripheral chemoreceptors were more sensitive to O2, and those will actually be more sensitive to hypoxia. So the scenario here says a patient with chronic bronchitis has a barrel chest and cyanosis. Pulse ox breathes 86% oxygenation, and his PO2 is 54 millimeters of mercury, right? So we're saying that that's definitely hypoxemia. And his PCO2 is 56 millimeters of mercury, which we know that's definitely hypercapnia. because normal PCO2 in the venous blood should be around 40 millimeters of mercury. So as a result, they put him on low flow oxygen, but he still complains of shortness of breath. So somebody turns the O2 flow up, and later he's found in a coma with a PCO2 of 59, so CO2 levels actually went higher, and his blood pH is now down to 7.2. So the question here says, what was the cause of coma and why? Well, remember we talked about how with respiratory disorders, individuals can have low O2 and high CO2. One of the stronger sort of effects to ventilate is O2 levels. So if someone puts his O2 flow up too high, such that it gets up so much that it reverses his hypoxemia, it's possible then that in this individual with higher O2 flow, that its O2 levels were normal, but his PCO2 was still high. Now, if your O2 levels are normal, that's going to really decrease your drive to ventilate, because O2 is a stronger stimulus to ventilate than CO2. So if his O2 levels were, high or normal as a consequence of, oxygen flow, he might stop ventilating even though his CO2 levels are still pretty high. And this would explain the fact that, his blood pH is also more acidic here. And the coma would come from the fact that he's undergoing hypercapnia. Remember we said that coma was one of the later, more severe symptoms and signs of hypercapnia. So in terms of the consequences of COPD, exhalation is inefficient, and O2 levels in the lungs can decrease. If blood goes to the lungs and fills with stale air, it might not pick up as much oxygen. And if that CO2 is trapped in the lungs, it actually might even pick up excess carbon dioxide in that stale air. So the question here says, what will the pulmonary arterioles do as a consequence? And which side of the heart will be more likely affected directly? Well, we know that through ventilation perfusion matching or coupling, we said that if CO2 levels were too high within the alveoli, that causes vasoconstriction of the pulmonary arterioles, because you don't need to send blood flow to poorly ventilated alveoli. So the problem here then is that with COPD, and it affects most of the lung, if the lungs had a lot of vasoconstriction, this is going to put a lot of stress on the right side of your heart to try to pump blood to the lungs because of that increase in resistance from vasoconstriction. The vasoconstriction would be your lungs' attempt to try to, have proper ventilation perfusion coupling or matching. But in this example, it's actually making the problem worse because it's so widespread that such widespread vasoconstriction puts a lot of stress on the right side of your heart. And this can lead to Cor Pulmonale, which is right-sided heart failure. So another type of pulmonary condition we've talked about is cystic fibrosis, or CF. Cystic fibrosis was actually, remember, is one of the most common autosomal recessive disorders in people of European descent. It seems to actually limit your ability to be infected with tuberculosis. But what's interesting, though, is that we consider this a disease because it's life-threatening. In fact, half of individuals with cystic fibrosis will die before age 30. And what the problem here is we see high concentrations of sodium chloride in sweat, but there's less sodium in water and respiratory mucus. And so these individuals will have a lot of salt in their sweaty secretions, but less sodium and water in their respiratory mucus and other secretions like pancreatic secretions. So the problem here is that they make really thick, sticky, tenacious mucus. The mucus is so thick here that it obstructs their airways, and it can even obstruct things like the pancreatic and biliary ducts of the digestive system. So in terms of the pathogenesis of cystic fibrosis, we find is actually a defect, the CFTR gene here, found on chromosome number 7. It's a defect in this chloride transporter, so that individuals with cystic fibrosis can't transport chloride properly. But you need to transport chloride to have proper water osmosis to make mucus. Now, that due to a defective chloride transport, they move less water and less sodium, so as a result, the mucus that they do make is more viscous. It's more sticky and more tenacious, and this causes a decrease in mucociliary clearance, which leads to chronic airway obstruction. Now, if those airways are obstructed, bacteria are more likely to get trapped in that sticky mucus, which actually causes an influx of neutrophils. That leads to the release of elastase, which we call was trypsin, and this can damage the airway, but also put individuals at risk for respiratory infection and possibly even respiratory failure if their airways have too much mucus. So this discussion here says a client with cystic fibrosis is having respiratory problems, digestive problems, flatulence, steatorrhea, and weight loss. So the question here says how he does not understand why respiratory disease would cause these problems, and how would this be explained to the client? Well, we talked about how with cystic fibrosis, it's a defect in a chloride transporter. The respiratory problems come about from the fact that there's sticky mucus that's accumulating in his airways, and that can lead to respiratory disease. And then the digestive problems come about because along your digestive tract, you also have mucus, because your digestive tract is a mucous membrane, just like your respiratory tract. So that we see as a consequence of maybe a plugged pancreatic duct or a plugged bile duct, you have a decrease in digestion. And so this is going to explain flatulates, because if there's more nutrients left behind in the colon, bacteria will use as nutrients. So you get a lot of bacterial growth that causes a lot of gas. And it's also going to explain the weight loss, because if you can't digest those nutrients, then they can't be absorbed. And so this individual might be eating a normal amount of food, but not properly absorbing that food due to plugged bile and pancreatic ducts, so you can't get the digestive enzymes in the digestive tract properly. So other conditions that can affect the lungs would be things like pulmonary emboli. We talked about this as a consequence of things like venous stasis and hypercoagulability, but this is actually showing the pulmonary trunk where it splits into the right and left pulmonary arteries, and it's been dissected here because now you can see the embolism blocking this vessel. And the embolism is a large blood clot in this example, which can limit proper blood flow to the lungs. So a pulmonary embolism can cause respiratory failure through a decrease in blood flow to the lungs, so that individuals don't get proper oxygenation of their blood and their tissues respectively. Now, what would put you at risk for pulmonary emboli would be like hypercoagulability disorders, or venous stasis, like if you have damage to the veins in your legs, that can actually cause thrombi that can dislodge and form emboli. We also talked about how arrhythmias can put you at risk for pulmonary emboli, because let's say if you have an arrhythmia of like the atria, and that you get turbulent blood, turbulence in blood also puts you at risk for clots, which can travel to the lungs and block the lung tissue. Now, pulmonary hypertension is basically just high blood pressure in the lungs, but there's secondary and primary causes. Most common cause of pulmonary hypertension is secondary. So this could be high blood pressure in the lungs, secondary to things like secondary things like left-sided heart failure, or obstructive disorders of the lungs. But ultimately, this is going to lead to an increase in pulmonary venous pressure, and that's going to lead to more fluid being forced into the lung tissue, and so this is going to be associated with pulmonary edema. Now, pulmonary hypertension may increase pulmonary blood flow, but can also be caused by pulmonary vascular obstruction or even hypoxemia. Now, the primary cause of pulmonary hypertension is going to be due to damage of the blood vessels that you find in the lungs itself. However, this is much more rare, because you're talking about this is going to be basically a primary disease of the blood vessels within the lungs itself. So this is where the walls can thicken and constrict within the lungs. So with the pulmonary arteries, let's say if it's primary hypertension, with a normal pulmonary artery, you're going to find your intima, your media, and externa layers. And usually the media is pretty thin, so you have a nice wide lumen. Now with pulmonary hypertension, let's say if it's primary, early on, you see actually hypertrophy of the musculature here, which causes narrowing of the lumen, so you get more resistance and less flow. And then in late pulmonary hypertension, you can actually lead to fibrosis of the intima, such that there's a lot of scar tissue or fibrotic tissue that builds up between the media and intima, and that really limits the diameter of the lumen. In fact, you can see that here in this example, cross-section of the lung tissue. This is going to be a pulmonary artery, and you can see that due to thickening of the pulmonary arterial wall, like this is the lumen now that's left. And there's really not much lumen to even show in this picture. So with Cor Pulmonale, we said it's right-sided heart failure, secondary to lung disease. So this is going to be where you have excess stress that's placed on the right side of your heart to try to pump blood to the lungs. It may cause decreased lung ventilation or pulmonary vasoconstriction. It's going to put a lot of workload on the right side of your heart and ultimately lead to a decrease in oxygenation of your tissues. Now, your kidneys can release erythropoietin from hypoxemia, causing more red blood cells to be made. But the problem, though, is that if you have more red blood cells, your blood's more viscous from that polycythemia. Remember, viscous blood is more resistant to flow, and that's going to put even more stress on your heart as well. So that, in the long run, the hypoxemia from a decrease in blood flow to the lungs causes your blood to become more sticky or more viscous because there's more red blood cells made, and that's going to put even more stress on your heart. Now, with acute respiratory distress syndrome, or ARDS, it sounds like when we talk about infant respiratory distress syndrome, but there are different pathogenesis here. An acute respiratory distress syndrome is a really severe disorder where, due to damage of the alveolar wall, exudate enters the alveoli and blocks proper gas exchange. This makes inhalation very difficult. You can see this with burn injury, where that smoke inhalation could damage the alveoli, causing ARDS. Now, neutrophils can also enter the alveoli and release proteolytic enzymes and reactive oxygen species that cause further damage of the alveolar septa. So if you look at the pathogenesis of ARDS, there's some sort of precipitating damage here that causes sloughing of the type 1 alveolar cells. Now, damage can come about in a wide variety of ways, but ultimately, when you lose the alveolar cells here, you see that there's going to be protein-rich, exudate that really gets forced across this damaged wall and enters the alveolus. Now, this can actually cause an inflammatory immune reaction where macrophages and other leukocytes, enter the alveolus and start to clean up this debris. But they also release things like proteases and different reactive oxygen species that can further damage the wall of the alveolus. Now, over time, you can see the accumulation of fibrin. And this fibrin can come about from exudate, like if it's a fibrinogenous exudate. This fibrin can build up within the alveolus and really limit proper expansion and maybe even cut off proper air flow by blocking and occluding the lumen here. Now, neutrophils can actually migrate from the bloodstream and enter the alveolus as well. And you can find things like plasma proteins start to accumulate within the stroma of your lung tissues, and that can lead to pulmonary edema. Now, due to damage of the type 2 cells of the alveolus, you can see that they get less surfactant that's being produced, and even if there is surfactant present, it might be damaged by some of these reactive oxygen species released by your leukocytes. And so that with less surfactant, it makes the alveoli even more sticky, so the walls of your alveoli stick together. So ultimately, with ARDS, you're going to see destruction of the alveolar membrane, an inflammatory immune reaction that ultimately causes a decrease in proper respiration and a decrease in lung compliance. So this is an acute issue that can lead to respiratory failure. So this question here says, true or false? Patients suffering from ARDS will not necessarily be hypoxemic. And that's absolutely false. From the last slide, we saw that with acute respiratory distress syndrome, there's such widespread destruction of alveoli, and they're going to fill with exudate, and you're going to get so much inflammation that's going to ultimately limit proper gas exchange, and they will definitely become hypoxemic. In fact, that's ultimately what helps differentiate ARDS from other disorders, is that if you get extreme hypoxemia, then that's going to be ARDS. So other causes of respiratory failure could be things like hypoventilation. This could be neuromuscular. This may come from depression of the respiratory centers or inhibition of the respiratory nerves and muscles. In fact, it came out recently that the leader of North Korea, Kim Jong-un, actually killed his half-brother in Malaysia using a nerve agent. And this particular type of nerve agent inhibits the enzyme called acetylcholinesterase, which you use to break down acetylcholine. Now, he died of respiratory failure, not because of an inability of your respiratory muscles to contract, but rather they stayed contracted too long. Because if you allow that neurotransmitter to build up in the synapse, then your muscles stay contracted. But as we've learned, relaxation of the respiratory muscles is important for proper ventilation. So that If your respiratory muscles stay contracted, that can also lead to respiratory failure. That's also what sarin nerve gas does. Now, this can also come about from ventilation-perfusion mismatching, like if you get inadequate, matching of perfusion to ventilation. For instance, what if you sent too much blood flow to poorly ventilated portions of your lung? Then that can absolutely lead to respiratory failure. But it can also come from impaired diffusion. If you remember, diffusion is dependent on distance. So diffusion rate is actually inversely proportional to diffusion distance. So what happens here then is that if you have any disorder that causes the diffusion distance to increase, your diffusion rate will be slower. So you might wonder, well, what does that mean, diffusion distance? That's going to absolutely relate to the thickness of the respiratory membrane. So if there's anything that makes the respiratory membrane thicker, that's going to decrease diffusion rate. And so all of these thicken the respiratory membrane. Interstitial lung disease, acute respiratory distress syndrome, pulmonary edema, pneumonia, all of these cause thickening of the respiratory membrane, either by thickening of the tissue or by an increase in mucus that makes that respiratory distance even farther. And so that impaired diffusion can lead to improper gas exchange and ultimately respiratory failure.